So our first video today is going to demonstrate how I would anesthetize a wound prior to stapling or suturing. And I'll show you another variation as to another appropriate fashion in which to anesthetize a wound. So I have all my supplies. I have gloves. I have some 2x2s and 4x4s. I have my aseptic cleanser. I do have some alcohol pads in case I need them. I have a 10cc syringe because you're probably going to need a little bit more anesthetic than would be provided in a 3 or 5cc syringe. For the case of today, I have a 23 gauge, but normally you would use an 18 gauge needle to draw up your medication, a 27 gauge needle to inject your anesthetic, and essentially my lidocaine. So first and foremost, I want to cleanse my wound. So I'm going to don my gloves. This is a healthy patient who came in today, and they've been at home on quarantine doing some yard work, and they had a nice clean laceration, single laceration, secondary to some work that they were doing around the house. So first and foremost, we're going to cleanse that wound as much as possible. There's a couple different ways that you can do that. You can certainly use some saline and a separate syringe and actually irrigate into that wound. Again, the solution to dilution is dilution, so that would be great. Other way to do it would be to use some type of aseptic skin cleanser. So we don't like to use hydrogen peroxide over and over again, remembering that that's going to kill both the good as well as the bad flora. But you can pour some of your chlorhexidine or your betadine, as long as they do not have an allergy. Oftentimes your chlorhexidine will come in a administrated dose that you simply have to activate, but you can cleanse and wipe off that area. Again, going from the center and out, putting that down. Let's grab some more. Let's go from the center and circular pattern out to cleanse that area. As that's drying, I'm going to draw up my lidocaine. So I'm going to get my 10cc syringe ready. And I'm going to attach what would be my 18 gauge needle. I'm going to pop the top. And I'm going to go ahead and pull up because I think I'm going to need quite a bit of anesthetic for this patient. So I'm going to go ahead and drop 10 cc's of air. Take the cap off the needle, invert my vial, push the air into the syringe, into the vial, and just let that fluid come back at me. Always keeping that I'm actually into the liquid itself, pulling back if I need to, okay? Now, if you did what I did and you actually got too much air at the top, you want to go back and you can push some of that air back into your vial and then let that area and that fluid come right back at you. Again, this is passive, ensuring that your needle is within the liquid, kind of pulling that down to the rubber stopper if necessary, and then if you need to, you can just pull back on the fluid. This is why it's easier to use a larger gauge needle, because you'll be able to withdraw the medication certainly much more rapidly. Take this off, put my anesthetic down. I'm going to safely recap my needle. I want to just push it into the plastic, pull the needle up, then taking the sides, push that down, take my needle off, open up my 27 gauge. Again, at this point, that chlorhexidine should have completely dried on my patient. Attach my 27 gauge, and I'm ready to anesthetize my patient. Now, one of the videos that we saw in the lecture actually has you anesthetizing the outside of the wound. That is extremely appropriate for your patients. This is a smaller gauge needle. I don't need this to go quite as deep because the patient didn't have any muscular involvement. But you can kind of tap this needle, get that little air bubble to come all the way to the top. Make sure you have a little bubble of anesthetic so that as you go in, if you're going to do outside of the wound, you're going to barely place the bevel of the needle underneath the skin, push a little bit of your anesthetic in, and then you would actually want to dive the length of the needle, and as you come back, you want to withdraw as you're injecting your anesthetic. Now this pad actually is going to leak the fluid underneath, but you get my drift. You would go and do this multiple times. A little bit of anesthetic in an area where you've already had it set in, push, and then subsequently as you're pulling back on the needle, inject your anesthetic. You got to be very, very cautious and just aware of the fact that you need to appropriately anesthetize both the distal and proximal ends of your wound. And so oftentimes when I'm injecting a wound, I actually will open the wound just slightly, and honestly, most patients, because of the tension naturally on the tissue, the wound will be open. And I prefer to go into the wound itself, again, still remaining in that subcutaneous space. I do not want this to be an intramuscular injection, so I'm remaining at that angulation of about 45 degrees, maybe even a little bit less, down to 30 degrees, injecting a slight amount of medication, and then pushing the needle, burying that into the wound. And as I withdraw the needle, the syringe and the needle, I'm injecting the anesthetic, okay? The nice thing about doing that is when you go distal and proximal, you're going to, again, go to the very end of your wound, inject a slight amount of medication, go beyond the length of that wound, and then you are injecting medication into your patient. If this is your patient and you don't want to switch hands, which is often the case, but now they're better anesthetized, you have the option to then flip the syringe around, okay? Again, remaining that the needle is bevel up, and I would actually come at the patient with my still dominant hand, going into the proximal aspect, injecting a little bit of medication, and as I withdraw the needle in the syringe, injecting additional anesthetic into that patient. I haven't draped my patient at this point in terms of staple repair, suture repair. I have plenty of time to do that because the anesthetic is going to take a little bit to work. Remember, your lidocaine is quicker onset. However, the half-life of the drug is less. Lidocaine, plain lidocaine, will typically last about an hour. Adding epinephrine adds roughly 15 to 30 minutes to your overall anesthetic time. Marcaine, also known as bupivacaine, will last anywhere from about 4 to 6 hours. However, the onset of that drug is much longer. So doing the technique of injecting a little bit of medication and then advancing the needle, please don't expect that patient to immediately have that therapeutic level of anesthetic. They're going to feel the needle pass in. The nice thing about bupivacaine or Marcaine is that A, it gives you a longer time to suture that patient, and it gives them anesthetic effect for roughly 4 to 6 hours. So even if it only takes you an hour to sew them back together, they will not have any discomfort for several hours after their discharge. Once I am done with this, there is no need to safely resheath this needle. This needs to go with the remainder of the lidocaine directly into the sharps container. If you have any questions or concerns, please let me know.